Welcome to this webinar entitled Von Willebrand Factor, Friend or Foe? And now let's get started with the webinar. Our moderator is Mr. George A. Fritzma. Mr. Fritzma holds a master's in medical laboratory science from Wayne State University and advanced coursework from the University of Illinois at Chicago. He consults for the Laboratory Medicine Division of the University of Alabama Hospital and is a contributing author for Rodax Hematology, published in 2020. George is a scientific advisor for Biomedica Diagnostics, Inc., and he manages the Fritzma Factor, your interactive hemostasis resource, at fritzmafactor.com. He will be sharing his own insights and that of his esteemed guest to help you better understand the connections between hemostasis and von Willebrand factor. Now I'll pass it on to Mr. Fritzma.
Thank you, Rose, for that introduction. First, I'll start with our learning objectives for today's webinar. We're going to review the physiologic relationship of von Willebrand factor with platelet function coagulation and the enzyme ADAMTS13. We'll look at some of the things that can go wrong and cause imbalance between ADAMTS13 with von Willebrand factor, and especially the ultra-large von Willebrand factor multimeres. Next, we're going to look at the reasons and needs for measuring ADAMTS13 and ways to do it. And then we'll also employ some emerging ADAMTS13 therapeutic preparations for uncontrolled von Willebrand factor activation. Here's how we'll proceed. Dr. Zheng will give a brief introductory presentation, followed by a dialogue between him and me. We will then wrap up with an opportunity for participants to ask questions through the Q&A, not the chat box, but the Q&A box. Now it's my pleasure to introduce today's presenter, Dr. Long Zheng. Dr. Zheng is chair of pathology at the University of Kansas School of Medicine and Medical Center in Kansas City. He earned his MD from Nanchang University, his PhD from the University of Vienna. Dr. Zheng has served on the faculty of the University of Pennsylvania, the University of Alabama, where he is the director of laboratory medicine before coming to Kansas. Dr. Zheng is an expert in the diagnosis and management of thrombotic thrombocytopenic purpura, or TTP, and was among the first scientists who identified and cloned ADAMTS13, a critical enzyme involved in TTP. In addition to his role as an educator and his multiple publications, Dr. Zheng chaired the ISTH committee to develop recently published guidelines for TTP diagnosis and management. I'll now turn over the discussion to Dr. Zheng for an introduction to today's material.
Can you see my slide? Thank you all for joining the webinar this evening or night or morning, depends on where you are now. So thank you, George, for such a kind introduction. And it is my great pleasure to have the opportunity to discuss with you today about the von Willebrand factor, the friend or foe. This is my disclosure slide. So as you might be familiar with, von Willebrand factor is a large multimeric glycoprotein. It's named after Finnish physician Erik von Willebrand factor, who first reported a family with a serious bleeding disorder affecting consanguineous families. The problem was a 5-year-old girl with severe bleeding since birth. 3 other sisters had died before age of 4. And 1 living sister, age 3, also was severely affected. Von Willebrand factor was, at the time, had thought that it was a disorder of platelet function disorder and the vascular defect as the potential cause of the bleeding. However, only until 1985, van Willebrand factor was first cloned and identified by one of my mentor, Dr. Evan Sadler at Washington University in St. Louis, and also by others, such as Dr. Ginsberg from the University of Michigan. The molecular cloning has opened the avenue for understanding the biology of van Willebrand factor and also van Willebrand disease. As is shown in this slide, van Willebrand factor is actually made as a pre-pro van Willebrand factor, Willebrand. And this propeptide was cleaved and then have the mature van Willebrand factor actually consist of multiple domains. So there's starting from D prime D3 domain, which actually binds to factor 8 to stabilize factor 8 in the circulation. You also have this A1, A2, and A3 domain. So for example, A1 domain binds to platelet GP1B, so they interact with platelet. Type A3 domain interacts with collagen, so they can actually bind to subendothelial matrix. The C domain also involved in integrin binding, as well as the disulfide bond formation between the protein. In the A2 domain, you have this tyrosine 1605 to and the methionine 1606, which can be cleaved by this enzyme, ADAMTS13. Van Willebrand factor is actually made in the endoplasmic reticulum as a single polypeptide, and then two molecular actually form tail-to-tail disulfide bond. And this dimer actually further multimerized by form head-to-head disulfide bond after this propeptide cleaved. And of course, in the meantime, they acquire glycosylation, various glycosylation. And this multimer and eventually get stored in the Weber-Palade body, or some of them will be secreted into the plasma constitutively. And so if you look at the plasma van Willebrand factor, they actually look like a ladder. So the smallest will be around this dimer, 500 kilodalton. And the largest will be about 20,000 kilodalton. So it's like a 2 million dalton. So it can be really, really large. And even the agarose gel cannot resolve them in the separate band. So this is actually very important because the larger the size, the more adhesive function and the more they stick to the collagen and the platelet. So what happens if the vascular endothelium get injured or activated? You can actually start to see van Willebrand factor release from this Weber-Palade body and actually form this string-like structure. It can be very long if it don't have ADAMTS13 to cleave. So this is actually under normal condition. You see a few strands formed on the top of the endothelial surface. When ADAMTS13 is not there, that cannot remove or cleave those unusually large strands, then it actually builds up on the endothelial surface. So you can see this strand decorated by the single platelet. You can see here, it's a really, really long strand. So this is after vascular injury in a mouse mesenteric artery in ADAMTS13 deficient mice. In contrast to the normal mice, you actually see only a very few and short kind of strain form. If you do laser injury, for example, you actually can see, so under normal condition, you see platelets sticking to this injured endothelial surface, which of course mediated through van Willebrand factor. If you don't have a van Willebrand factor, this thrombus formation will be very minimized. When ADAMTS13 is inhibited, let's say by an alternate antibody, you can see the thrombus formation is actually dramatically enhanced. And if you can pay attention to this little tail here, This is actually the unusually large von Willebrand factor aggregates and has not been cleaved by the ADAMTS13. So you can see this elongated shape, and this can fall up and jam the small vessel. That's called small vessel occlusion. So having a balanced von Willebrand factor and an ADAMTS13 ratio is critical for maintaining a normal hemostasis. Normally, you have about 10 units per ml of von Willebrand factor and 1 unit of 1 microgram of per ml of ADAMTS13. In terms of unit, they all called 100 units and 100 units here. So normal ratio will be 1. So this balance is very important to keep checking on your vasculature. When this balance is disrupted, for example, you're missing von Willebrand factor or von Willebrand factor concentration or synthesis is reduced, as you see in the type 1 von Willebrand disease. So this amount of von Willebrand factor is actually reduced. In the type 2 von Willebrand disease, actually the multimer, the high molecular weight multimer is actually missing. So whenever this happening, the hemostatic function will be reduced. In the type 3 von Willebrand factor, basically the von Willebrand factor is not made or secreted from the cell, so you will not detect anything in the plasma. So on the other hand, if von Willebrand factor spills too much, let's say in the patient with TTP, you're missing the ADAMTS13 or ADAMTS13 is inhibited, then the von Willebrand factor builds up in the plasma or on the endothelial surface. And in this case, you start to form a microvascular thrombosis like this occlusive thrombi in the heart and in the kidney. This actually causes organ damage and death. So to summarize, is von Willebrand factor a friend? And of course, the answer is yes, because it's necessary for hemostasis to stop bleeding, right? Is von Willebrand factor a foe? And the answer is also yes, of course, because if you have too much von Willebrand factor or von Willebrand factor getting too large, then you're actually causing thrombosis. So I think either one, both answers are correct. So this would be my summary slide. Yeah, so.
Okay, thank you, Dr. Zheng. Hope everyone can hear me. This is a great review, and we can understand the cause for TTP when we have too little ADAMTS13. What situations cause us to have ADAMTS13 deficiency?
George, that's a really good question. So I think in patient with TTP, there's 2 types of deficiency. One is called immune-mediated deficiency. Basically, you have acquired autoantibody, which is probably most patients. I would say 95 to 99% of patients. They suddenly develop some kind of antibody that actually bind and inhibit ADAMTS13 activity, or cause accelerated clearance of the ADAMTS13 enzyme from the circulation. The other form is actually an inherited form, which is actually have a mutation in the ADAMTS13 gene. So the protein either not secreted, or when they secreted, it was secreted defective protein. On the other hand, if there's truncation that in the gene, it causes a nonsense decay of the messenger RNA. So that therefore, you don't even have a protein that is synthesized. So this is in TTP. Of course, in other scenario, like in other disease, this may not be the cause. Most of them probably caused by inflammation and reduced synthesis or consumption. So there's a multiple reason that ADAMTS could be low.
Thank you. Give me a little bit of history of TTP, if you would. Did we know about ADAMTS13 back when we started treating it with plasma exchange?
Yeah, that's a great question. So let me see if I can find a slide to describe that. So this is a a slide that I presented in one of my review paper published in JTH a couple years ago, showing the milestone for how we understand the pathogenesis of TTP and how people try different treatment in terms of to get for patient to get better. So TTP is not actually a new disease, as everybody knows. It was described in 1924 by Eli Moskowitz, who is a physician in New York. And of course, this has not has much activity for many, many years. For example, only until 60s, people start to describe some maybe this patient caused by some kind of plasma factor, and particularly somebody believe that maybe thrombopoietin or something like that, the help making platelet is not there. So therefore, they started giving plasma, and so and for some reason the patient gets better. So plasma treatment is actually happening in the very early days, and of course through 70s and 80s, people continue giving plasma to some patients. Some even give a whole blood transfusion. Patient can also get better. So you can imagine maybe giving something that is actually missing. Okay, and really the understanding of a pathogenesis is actually not happening until 1982, when Joe Moak, who was a hematology fellow in Boston, described this in patients with chronic relapse in TTP. In their plasma, they actually have this called the unusually large von Willebrand factor circulating around. And he called this an evil humorous. And so he hypothesized that there may be some kind of enzyme that degrades this unusually large Willebrand is probably missing in this patient. And of course, the mystery has been gone for another 15 years until 1997 or 1998. Fuller and Tsai, they actually start to measure those enzymes that can degrade the von Willebrand factor. And they indeed identify in the patient with familiar TTP, they do have a deficiency of this particular enzyme. The enzyme cannot cleave von Willebrand factor. In the acquired cases, they actually, particularly for Tsai, identified this autoantibody that actually inhibiting this cleaving protease. Okay, and of course, people have tried to isolate this protease for many, many years until 2001, we and the other group simultaneously reported the identification and molecular cloning of ADAMTS13. So this really opens up how we actually understand a TTP. Okay, so of course the plasma exchange versus plasma infusion, which one is actually better, really come from this particular paper from Gail Rock, published in New England Journal of Medicine in 1991. They actually, Canadian apheresis group, compare the plasma infusion versus the plasma exchange, really show that plasma exchange is superior to the plasma infusion in terms of improving survival rate. So I can show you this one. So this is actually showing that plasma exchange is the patients survive much better, almost like 80%. And then plasma infusion also can get up to 70, 75%. And so this is really a milestone paper that's showing plasma exchange is the way to go to treating a TTP. So.
Thank you for that. When you look at this Kaplan-Meier chart, that's definitely an improvement, but it's still not perfect, is it? It looks like plasma exchange gets you to around 80% or so. Are you, when you're doing exchange, are you adding ADAMTS13, or are you taking out the von Willebrand factor multimeres, or are you taking out the autoantibody?
That's a great question, George. I think they're doing all of this probably at once. And so the goal is to plasma exchange is to remove the autoantibody, particularly the IgG antibody from the circulation. And at the same time, you replace with fresh frozen plasma. Of course, you infuse the missing enzyme ADAMTS13. You might, remove some of the ultra large von Willebrand effect as well, maybe including also the inflammatory cytokine, particularly during the acute setting. So I think we're doing all this all together. So this is a really good question. So.
We'll want to talk a little bit about therapy, some of the newer therapies that we have now for TTP. But first, would you distinguish TTP from the other thrombotic microangiopathies? I know there's hemolytic uremic syndrome and atypical HUS. And are they all the same? Do they all involve ADAMTS13?
George, that's a great question. I don't know if you see my slide. George, can you see my slide?
Yeah.
Okay, yes. So of course, TTP is caused by the deficiency of ADAMTS13. So as I just mentioned, normally if endothelial cell, if you get injured or get activated, von Willebrand factor will release and sit on the endothelial surface, right? So you require ADAMTS13 to remove that. And so that will not agglutinate all the platelet that are flowing by, right? When it comes to the in circulation, the Willebrand is now kind of falling back and forming like a ball. And in this case, the von Willebrand factor is resistant to ADAMTS13 cleavage, okay, until they encounter the shear stress. And then they open it up and then they will be cleaved as well. So this could happen at the site of vascular injury or at the site of thrombus formation. So normally you have this ADAMTS13, so you don't have any problem with excessive thrombus formation. When ADAMTS13 is deficient, now this von Willebrand factor cannot be cleaved, removed from endothelial surface. You can also not be able to degrade during the thrombus formation. So in this case, then this just keep building up, eventually occlude your vessel. So this is the pathophysiology of TTP. On the other hand, atypical HUS or HUS, of course, HUS normally caused by E. coli infection and mostly occur in pediatric who are, in children less than 5 years old. And most of them have renal failure, acute renal failure, but most of the treatment is basically supportive therapy. And most patients will recover, 95% will recover. So these are completely different category of HUS. What we are talking about here is a complement-mediated HUS. In the past we call atypical HUS. Okay, so what happened in this patient is they actually have inherited the mutation, and in probably half of the case, they actually have a loss function of this complement factor H, factor I, membrane cofactor protein, or thrombomodulin. So these complement inhibitor is important to shut down the complement activation. It's like the brake in your car, okay? So your car keep running with the complement activation, you need a brake. So if the brake is faulty, then you're gonna hit somewhere, and cause problem. So that's what happens. So, and also in small fraction of the patients, actually caused by an autoantibody that actually inhibit complement factor H or factor I, and that also causing the exact same problem. So the overall function is that complement activation, overactivated. So basically, that will cause the inflammation. It will also cause endothelial damage and platelet activation and thrombus formation. So this is a completely different mechanism how thrombus is actually formed from TTP.
Is it pretty easy to distinguish between these two? They look about the same on a blood film with the TMA picture. Can Can you just measure for the complement factors? How do you do that?
That's a great question. So I think it's not that easy to distinguish TTP from HUS. I remember when I was a resident at Washington University in St. Louis, and we treat everybody the same. Regardless is TTP or HUS, everybody get plasma exchange, okay? Because we have no way of distinguish them. So now we have a better tool, probably. Let me see if I can show you that. So to really distinguish TTP from an atypical HUS, of course, after you have to exclude other known causes for TMA, like DIC, like mechanical valve, like, malignant hypertension, and so on and so forth, and bone marrow transplant, for example, those kind of stuff. If you rule out this, the difficult differentiation is between TTP and atypical HUS, okay? So the way to distinguish is you look at the platelet count, okay? If a platelet count is less than 30,000, then it's actually more is in TTP, more actually seen in TTP. Also, the other thing to look at is renal function. If the kidney function is relatively preserved, let's say creatinine is less than 2.2 or 2, then this is actually more likely to be TTP. If the creatinine comes with 8 or 9, this patient probably is not TTP, okay? And of course, you also want to look at the response to plasma exchange. If you treated it by plasma exchange 3 to 5 times, you don't see any platelet increment, this patient may not be TTP. So that's another thing. But the most importantly, nowadays, we measure ADAMTS13 because we know the difference in terms of pathophysiology between TTP and the atypical HUS. Because TTP, you should have ADAMTS13 deficiency, while HUS or atypical HUS, you should have normal or close to normal ADAMTS13. So that's how we actually distinguish.
Well, that's great, but the way I remember it, the ADAMTS13 assay takes about 3 days, and it seems like you need the information faster than 3 days. Are we still doing it that way?
That's a great question. I did remember that it spent me 3 days to run the MTS13 as in the old days. So that almost like 20 years ago. So the way to
a little behind, yeah.
Yeah, I know. So the way to measure ADAMTS13 at the time was actually looking at whether the patient's plasma can cleave the purified van Willebrand factor or not. And then after the cleavage, you run multimer and to see if the multimer is actually degraded. So let me see if I can find a slide. So so this is actually assay initially described by Bernhard Lemley in Switzerland. This guy is phenomenal. So he took some purified van Willebrand factor and he denatured them first using urea and then use guanidine. Or you can use a shear. So when you do that, this ball, like a spaghetti kind of thing, start to stretch, okay, and start to loosen up. And when that loosens up, you actually expose the cleavage site, and then the ADAMTS can cleave. If you just taking the van Willebrand factor, adding ADAMTS without adding denature reagent, you will never get ADAMTS cleaved. So the cleavage site is actually buried inside. So when you do that, so this actually done in a filter. So they have to incubate it overnight, and then after cleavage, you run agarose gel. So now you look at the multimer. If this is a patient's plasma added to this, and you see the multimer, no change. If it's normal, you actually, this multimer degrade into very small. So and then you can look at the brother, sister, other, family member. Mother has normal ADAMTS, father has a normal ADAMTS, sister has a normal. But this brother, even though it's asymptomatic, but still have the deficiency. It's just the TTP hasn't developed yet, okay? So this is actually the way how you determine ADAMTS activity in the old days. This whole process take about 3 days, indeed, That's how I use this method to isolate ADAMTS13 from normal human plasma and then clone ADAMTS13. You know how much time that I spend in the laboratory doing this. Yeah.
Are there some newer ways of doing it?
Yes, George, I'm glad you asked that. So thanks to Kokame from Japan, he actually, this is a really smart guy. He's a biochemist. And we actually trained together with Evan Sadler in St. Louis. And he went back and actually started to mess up the von Willebrand factor. And he started to chop the von Willebrand factor into pieces and to see what will be the smallest piece that can be cleaved by ADAMTS13. And he found out that you actually need 73 amino acids for the ADAMTS13 to be able to bind and cleave it. Anything shorter than that, it won't work. So this is amazing. So this has become a substrate for the recent analysis. And so he developed this called the FRET assay, which is fluorescent resonance energy transfer assay. The basic principle is basically you label on either side of the cleavage side with two fluorescent, either one fluorescent dye, one quencher. So when they are together, they don't fluorescent. They cancel each other. Okay. When this tyrosine methionine bond get cleaved by ADAMTS13, and suddenly this fluorescent, have no inhibitor, so it's just fluorescent. So you base on the amount or on the rate of fluorescent generation, you actually can estimate how much ADAMTS13 is generated. So this is a really revolutionized how we can measure ADAMTS13 in a rapid and a faster way. So.
Any other ways? Has it been automated, for example?
Yeah, so a couple years ago, another guy from Japan, in Kato, another brilliant scientist, he actually started to screen the monoclonal antibody to see if he can find a monoclonal antibody that can recognize only cleaved peptide, the 73 peptide. And he found this, this N10, this monoclonal antibody can recognize this last 12 amino acid or 10 amino acid actually that this monoclonal antibody can bind. If this peptide is intact, the monoclonal antibody doesn't bind. So with that, he initially reported this in transfusion using this ELISA-based. He immobilized this substrate with GST tag, and then he looked for cleavage by using this monoclonal antibody. So this actually a chromogenic assay instead of the fluorescent energy transfer, which is a lot of laboratory doesn't have those instruments. And the ELISA plate, I think everyone, most of the lab will have that. So, but this assay, even though it's done based by ELISA, it's actually pretty cumbersome. You take 3 hours to run ELISA, and this actually lead to the automation of this particular assay, which I'm going to show you the next. So basically, the principle is the same. So instead of immobilizing them, the substrate on the microtiter plate, you actually immobilize it on the magnetic beads. So this way, you can actually, washing off the stuff that cleave off, and so leave this actually on the magnetic beads, and you using another antibody, the same antibody N10, the label with peroxidase or whatever, that you can actually using chemiluminescent, which is the light to detect the cleavage. So this is actually now can automate it in the automatic machine. So this particular assay now can be done within 30 minutes. And so just push the button and the result will come out. This is what be revolutionized how we're gonna measure ADAMTS13 in the next few years. So I really, looking forward for this assay to be going live. Yeah.
Dr. Zheng, we want to move on to some of the other conditions that relate to deficiencies of ADAMTS13. But I want to divert a little bit here because I'm remembering a day when I was doing the lecture on multiple transfusions and trauma-induced coagulopathy for some of the residents at University of Alabama, Birmingham. And you were sitting in the room. I didn't know you. You were just sitting there. And in the middle of my lecture, I was talking about how to manage people after trauma and the coagulopathy. And I remember you said to me, well, what if you could just stop that right at the beginning, stop the coagulopathy? I thought, well, that's a great idea, but how are you going to do that? And so you brought up something at that time that I found to be really fascinating. So I want to take you to that discussion for a few moments, and then we'll look at some of the other applications and some of our questions. We've got 7 or 8 questions already waiting for us.
Yeah, George, I think this is a really interesting question because I've been wrestling for this question with a surgeon in UAB as well. So he saw a lot of patient coming to the pediatric patient coming into the hospital with trauma, and most of the time they see bleeding. But in fact, he told me that most of the patients not died of bleeding because you're resuscitating them, all kinds of stuff. Most of the patients actually died from organ damage resulting from ischemia, so microvascular thrombosis. So with that in mind, we actually did a study a couple years ago, and it's all published. So it's in the handout. You can look at that. Actually show that when patients have trauma or even brain trauma, whatever the trauma is, and they are in a very acute inflammatory response. So when you have acute inflammation, 2 things could happen. Number one, the von Willebrand factor released from endothelial cell, huge amount. It's maybe 2 to 3-fold increase from the baseline. At the same time, the inflammation suppressed the ADAMTS13 synthesis. So now you have 2 things going on. One goes up, one goes down. So the ratio of ADAMTS13 to β, you remember at the beginning, in order to have normal hemostasis, we need a 1-to-1 ratio. But in this case, the patient coming into the emergency room with trauma, they usually go down to 0.2 or maybe somewhere 0.1. So this is actually causing so-called a severe relative deficiency of ADAMTS13. You can imagine this patient will have microvascular thrombosis, which you don't see, on normally. You only see the bleeding, arm is broken, something like that. So I think in the future, what we really need to think about is how we can design a clinical trial to see if we can give those patients ADAMTS13, whether we can actually improve, the mortality, improve the survival rate, and reduce the mortality, and also the organ damage. Yeah.
And that was the part that surprised me, the fact that you were thinking in terms of an ADAMTS13 concentrate to be used therapeutically. And I've seen some publications from you on the use of that for TTP. What about some of these other applications?
Yeah, so recombinant ADAMTS13, of course, is the way to go for congenital TTP. So who have, mutation in ADAMTS13 gene, there's no ADAMTS13 made or functional in the bloodstream. So that's actually the clinical trials already, phase 2 trials already finished. So I hope that this will become available pretty soon in terms of treatment of congenital TTP. Also, people are thinking about using recombinant ADAMTS13 to neutralize whatever the antibody that in the acquired immune-mediated TTP as well. So I'm sure the clinical trials are also in progress. So hopefully by a year or 2, we will have this as an option to treating TTP. Right? But beyond TTP, I think there's a lot of other places, particularly in the inflammatory and thrombotic disorder. I can give you a list of that, including myocardial infarction, stroke, and for example, malignant malaria, for example, preeclampsia, and also recently the COVID-19 related thrombosis.
Mm.
All this has some component of relative deficiency of ADAMTS13 because the von Willebrand factor released so much and the ADAMTS13 was suppressed. So, this ratio just completely changed. Yeah.
This is what is kind of exciting information to me. If the MTS13 concentrate would work in all of these places, seems like you'd have to keep some in all the helicopters and all the EMS squads all around the world.
Yeah, that's the hope, I guess. So when I initially identified MTS30, I thought I was just study TTP pathogenesis, but it turned out that MTS30 probably played more role than just in the pathogenesis of TTP. But of course, a lot of this kind of thing is just right now, it's just conceptually, we're just thinking about it. We don't have the clinical trial data to support any of those use yet. So
let's go on to talk a little bit. We've got 2 or 3 minutes before we go to our Q&A. Let's talk a little bit. You mentioned COVID very briefly. Obviously, that's in the forefront of everybody's mind right now. Talk about what's happening with ADAMTS13 and von Willebrand factor in COVID. Are these important considerations?
yeah, George, I'm glad that you asked. I've been recently reading some of this article. It's actually fascinating. There's more and more data that actually comes out in this area. For example, this is one study that I'm going to show you. If you look at the von Willebrand factor in the patient with COVID, depends on the severity of this disease. So low risk, medium risk, high risk patient, you can see this von Willebrand factor increases dramatically. Of course, this is a far more than the baseline. The baseline will be around 100, right? 100 units per deciliter. This is already 2-fold, 3-fold increase. But if you look at a high risk patient, they're like a 5-fold, 6-fold increase, okay? And at the same time, if you look at MTS13, it's going other way around. Now, if you look at the ratio, of course, here's looking differently for the Willebrand to MTS13 ratio instead of ADAMTS to Willebrand. You can see that the higher risk of those patients, the higher ratio of von Willebrand factor ADAMTS13 activity. So you can imagine these patients, their vasculature are not maintained by the sufficient amount of ADAMTS13 for sure. So that could be contributing to microvascular thrombosis in these patients, okay? And of course, if you look at the patient with severe renal disease or renal failure, and the ADAMTS13 is actually to Willebrand ratio is actually lower. On the other hand, is Willebrand to ADAMTS13 ratio is higher, okay? And if you look at the mortality, really the patients who had normal ADAMTS13 here defined by greater than 70 units per deciliter, which is about 70%. And compared to patient with less than 70%, you can see dramatic difference in terms of the survival probability, just looking at the COVID patients. So this is amazing. So, if you have ADAMTS13 available, if you give those patients, they probably will survive. I don't know whether that's the case, okay?
That seems like really exciting information, and physicians everywhere are looking for a way to measure and predict the progression of COVID, which is pretty difficult to do. So that looks really exciting. Looks like we better get to our Q&A. We've got a lot of questions here. First one comes from Stephen Bellows. He says, an absent ADAMTS13 with a long von Willebrand factor structure, can it break off from the endothelium and become an embolus?
Yeah, that's a good question. That's what is actually happening. Because when you don't have ADAMTS13, the Willebrand still going to be fall off at some point because, besides ADAMTS13 that can cleave von Willebrand factor, there's also other protease released from neutrophil, for example, like a proteinase 3 and some other protease can also cleave, like even plasmin can cleave von Willebrand factor, but it's just at a very low rate. So you can imagine they can fall off, when they build it too much and with the plate sticking on it. And but if they remove by some other enzyme, they could actually embolize the cause embolism in the small vessel. Yes.
Very interesting. Here's one from Larry Smith, colleague and friend of mine out in California. Dr. Smith asked, do patients with von Willebrand disease due to decreased synthesis have a decreased risk for TTP?
That's a really good question. Actually, a lot of people has asked that. So I guess is we have not looked at that. Nobody actually looked at the von Willebrand disease patient, actually the incidence of TTP, because TTP itself, it's a rare disease. So it's like a 3 to 7 per million, population. So you may not be able to see one in the von Willebrand disease patient. So yeah, it's very hard to study to look at that.
Okay, thank you. This is from Sanjeev Gupta. Asks, we know that the von Willebrand factor is made in endothelial cells. Where is ADAMTS13 made, and are there genetic mutations leading to the deficiency?
That's a great question, Sandy. Yeah. So von Willebrand factor, of course, is made in all endothelial cell, but the ADAMTS13 is primarily made in the hepatic stellate cell, which is the interstitial cell in the liver. That's the main cell that making ADAMTS13. Also, the small amount of ADAMTS13 can be detected in the endothelial cell. But if you think about endothelial cell is everywhere, so the endothelial cell may also contribute to some degree of ADAMTS13 in circulation. And also there's data to show that megakaryocyte or podocyte in the kidney could also make a small amount of ADAMTS13. And recently there may be placenta cell could make some as well. So the ADAMTS13 seems to be made in a lot of different places. But I think most convincingly is in the stellate cell, in the liver, and also endothelial cell. Megakaryocyte, how much they can make, I don't really know. Yeah.
Have we done any sequencing to find where those mutations
Yeah,
are?
definitely. So in particular in patients with congenital TTP, they sequenced all of the patient. Almost everyone has a mutation. The mutations is spread all over the gene. There's no hot spot, okay? But most of the mutation, if you will, is causing the secretion defect. So the protein somehow misfolded and cannot get out of the cell, so therefore you don't have any detectable ADAMTS13.
Okay. This is from Marina Martinez Vargas. What happens with the proteolytic fragments of von Willebrand factor? Do these have beneficial roles?
I don't know. So maybe because smaller Willebrand may be kind of like a feedback inhibition, because if they bind to platelets, for example, they don't cause thrombosis, but they may be, competing the larger von Willebrand factor for function. I don't know the report that actually demonstrated is actually having inhibitory activity. It could be, yeah. The smaller one probably counted. Yeah.
Thank you. This next question is from my colleague and friend and former student, Brianna Miller at UAB. She's asking, are TTP and HUS still commonly confused clinically, or is that more a historical thing?
I think now I would say if you really paying attention to the patient history, clinical presentation, laboratory result, plus ADAMTS13 measurement, I think we can probably differentiate 95% of the patient very clearly. So we hardly now confuse the TTP and HUS and lump them all together. Everybody get plasma exchange. Doesn't happen anymore. Only if the patient arrive on Friday evening when the ADAMTS is not available, because as many of you know, a lot of places don't do ADAMTS in themselves. They send it out and now waiting for 3 or 4 days. When that happens, you always err on the caution side, so that you always giving the patient plasma, just in case this patient has a TTP. But in large part, if we have the assay right away, we can tell, it's a TTP or HUS pretty much.
And I know you mentioned this before, but the therapy does differ between TTP and HUS. Is that right?
Yes. So 20 years ago, there's no difference because we don't have another drug or method to treat atypical HUS, right? So everybody get plasma exchange, corticosteroid, or something. But only the last 4 or 5 years now we have a specific treatment for atypical HUS, which is the anti-C5 monoclonal antibody. It's also called the eculizumab. Okay, this has actually revolutionized how we treating atypical HUS, and also point to importance. We must differentiate TTP from atypical HUS because in contrast of atypical HUS, we treated with eculizumab. TTP now is treated by plasma exchange, corticosteroid, rituximab, and capivasertib, which is a monoclonal antibody targeted van Willebrand factor A1 domain and block platelet van Willebrand interaction. This way, you can block immediate thrombus formation. So actually has been shown recently in several, in 2 random trial that actually show you can actually accelerate the recovery of TTP. Yeah.
Are you using capivasertib there in Kansas?
We have not started including in the formula yet, but we are using ad hoc for individual patients, some patients. But at UAB, I know we actually worked really hard to include them into the formula, the pharmacy formula. So now every patient will be, supposed to be treated by the capivasertib, which is recommended by the ISTH TTP guideline.
Great, yeah. Jing Jin out in California asks, now the lab can offer ADAMTS 13 result within 2 hours. I think she's just offering that as information. That's correct, right?
That's a possible. So depends on which assay you're performing. For the FRETS assay, inside the laboratory, it only take less than 60 minutes to run. You can run 30 minutes, so if you will. So you actually can get the result within an hour or 2. But of course, most lab doesn't do in their own lab, so they have to ship. So there's UPS or FedEx time that you have to calculate, and that adding another day. So usually 24 to 48 hours, and most places will get the result with that. Yeah. But in the future, if we had this automated assay with very specific and highly sensitive, I think that will improve how we treat patients. Yeah.
Very good, thank you. This question was partly answered. Dave McGlasson was asking, are there plasma-derived ADAMTS 13 concentrates that are readily available to treat active bleeding patients at this time?
No, there's no plasma derived concentrate. Unlike factor VIII, we don't have a plasma derived of ADAMTS 13 available for treatment. Mm-hmm. What the people are actually doing a clinical trial or being published is actually recombinant ADAMTS 13 made from the cell, from the human cell. Yeah.
That would be exciting, yeah.
Yeah.
And Sanjeev Gupta asks, what are the prospects for gene therapy?
Oh, that's a great question. So now it's almost like 15 years ago. We actually, when I was at the Children's Hospital of Philadelphia, we did develop AAV8-based gene therapy. We give a mouse 1 dose of AAV8 the mouse can express ADAMTS13 for the entire life. So, but we did not actually pursue further to develop into human trial because it requires substantial amount of resource to do that. So we kind of leave it there. We publish in Blood, and if somebody is interested, I can work with you to develop this as a novel therapeutic for at least for congenital TTP. So.
Very good. See, Dave McGlasson is asking, he's asking a question, is there a way to balance ADAMTS13 in COVID's subjects for experiencing thrombotic situations?
So, in fact, there's a plasma exchange already applied to treating severe COVID patients. And they actually show beneficial, a benefit for those patients in terms of survival. So you can imagine, the same principle that we use for TTP, you kind of remove acute cytokine storm, and release the unusually large beta breath. And at the same time, you're giving back some more ADAMTS13, using the fresh frozen plasma. So I think there's a utility of that. That's the way we have so far. But if we have recombinant ADAMTS13, I would be very interested to treat those patients or do a clinical trial to see if a recombinant ADAMTS13 will actually reduce the mortality, particularly in those very severe patients.
Great, yeah. I'm combining a couple of these questions along the way so we can squeeze most of them in if we can. And this one was interesting to me. Is there a downside to administering the ADAMTS13 that might allow increased circulating levels of cleaved von Willebrand factor, thrombotic risk?
So far, I don't think there's any downside. We actually did this in the animal model. We give a mouse, significant amount of ADAMTS13. There's no bleeding disorder. The reason is ADAMTS13 doesn't just go around and cleave beta breath unless the beta breath gets stretched, or unless they are released from endothelial cell, sitting on the endothelial cell, anchor on the membrane so that the cleavage site is exposed. So they are not just unlike a TPA that we use to treat for thrombolysis. You actually go around, chew up all the fibrin or fibrinogen, whatever. And ADAMTS13 is quite safe. If you were, I think even you give them 5 times more, I never seen a bleeding happening in the animal. So yeah, so it's probably one of the safest drug.
So a free lunch.
Yes.
Yeah. Skipping a couple, I want to get to some others here. This is from Dr. Manuel Favaloro in Sydney, Australia. Some workers use ADAMTS13 von Willebrand factor ratio, and others use a von Willebrand factor ADAMTS13 ratio. What's your preference and why?
It depends on what you study, right? So I prefer ADAMTS13 to von Willebrand factor ratio because I want ADAMTS13 to be the number one. So it doesn't really matter, either way. I think it's telling you, how relative amount of ADAMTS13 to beta breath. So yeah, you see that in the literature, everywhere. So.
Thank you. This is from Jaskirat. Just lost it. Hold on a moment here. Here we are. Aurora. Are the levels of ADAMTS13 antigen correlated to the enzyme? Would the levels of antigen be lower if the enzyme levels are lower?
That is true only in the patient without antibody. Okay. For example, in patient with a congenital TTP, yes, their enzyme and the antigen are, a lot of them are correlated because you just don't have anything secreted in the blood. Okay. So you don't have antigen, you don't have activity. For immune-mediated TTP, the antigen and the activity could completely dissociate it. So let's say the patient just arrived with TTP, you measure antigen can be normal, but these antigen are all bound with antibody. They are not functional. So, but during remission, I think the amount of antigen and the activity are really correlated. pretty well, actually. Low antigen, low activity. So high antigen, high activity. Yeah. And we actually have a paper published in Blood Advances a couple months ago. So if you want to take a look.
I can squeeze in about 2 more questions here. Let's see. I've got, this is from Kimberly Dugan, is use of convalescent plasma to treat COVID. Is the antibody to COVID, or is that the addition of ADAMTS13 that's related to the success of its treatment?
That's a great question. So this cannot be answered unless you get rid of the antibody, right?
Yeah.
No, I think it is a great question. Yeah, I didn't think about that way. But I
Yeah.
know plasma exchange, that's what we're doing. So we're giving more ADAMTS13, remove some beta breath, cytokine, whatever.
I've heard this, just an aside, but I've heard that the use of convalescent plasma has gone down. I checked, at UAB, they've only used it twice in the last month. How about in Kansas?
We don't use it at all now. We started in April, May, but we haven't used it now. Yeah, we stopped.
And I guess this will have to be our last question. Can patients with advanced liver disease develop TTP as a consequence of their disease?
No, actually not, because even your hepatocyte is died, let's say you have a hepatitis C or hepatitis, because ADAMTS is synthesized in the stellate cell, so the interstitial cell doesn't die. So they actually had a normal ADAMTS13. Most of them are normal ADAMTS13. Some patients may have slightly lower because of the inflammation. So yeah, I have not seen anybody develop TTP yet.
Okay. Well, I want to thank Dr. Zheng for this presentation and the information that we had. And I'm sorry I can't get to all of your questions. There were still a few left. I tried to combine where I could. But at this time, I'd like to turn our webinar back over to our host, Rose Patodia, and thank everybody for your participation.
Great, and thank you, Mr. Fritzma and Dr. Zheng, for that engaging dialogue. You had so many great questions today. We hope that everyone can leave the webinar with greater knowledge of the pathophysiology of ADAMTS13 deficiency and the relationship between von Willebrand factor, platelet function, coagulation, and ADAMTS13, as well as management approaches. This webinar was supported by an educational grant from Biomedica Diagnostics, Inc., a member of the Scotia Investments family of companies. On behalf of the sponsor and the speakers, thank you for attending this important webinar, and good night.
Thank you all. Thank you, George, and thank you, Ross.
Thank you too.
Thank you very much.
Take care, everyone.